All right, let's go ahead and go into the rapid review for today, which is on page 520. It is a short one, so it'll be nice and quick. So at the top of page 520, streak ovaries. Anytime you see streak ovaries, the first thing that should pop into your head is Turner syndrome. But also there's congenital heart disease. We'll learn later that the primary congenital heart disease you think about with Turner's is a coarctation of the aorta in general. And then Turner's is also associated with horseshoe kidney. So if you see any of those things, streak ovaries, coarctation of the aorta, or horseshoe kidney, I want you to have in the back of your mind Turner syndrome associated with either of those three. What else does it say about Turner syndrome there? It's chromosomal XO. So instead of 46 chromosomes, there's only 45 chromosomes. Short stature, of course, is a primary feature. Webbing of the neck, definitely important to know. And also you can have some lymphedema there. The next one, sudden swelling, painful, big toe joint and tophi are seen with gout. The big toe swollen and painful is podagra specifically. Hyperuricemia, which is elevated uric acid level in the serum, can predispose you to having gout. And we'll talk about this later, but just because you have elevated uric acid doesn't mean you're going to get gout, and patients with normal uric acid do also get gout. So it's not always associated with hyperuricemia. But what is a tophi? Yeah, tophi is it's these urate crystals. Whenever these urate crystals aggregate together and then create like inflammation around it, that's a tophi. There's actually a good image of this on image page 13, image 54A. Image page 13, 54A. So let's just take a quick look at that. So you see there on the left just aggregates of urate crystals and some inflammation around it with some neutrophils around it. All right, so back to page 520. Swollen gums, mucus bleeding, poor wound healing, spots on skin is classic for scurvy. Vitamin C deficiency. If you don't have vitamin C, you can't hydroxylate your prolyl and lysyl residues, so you can't make collagen. Swollen, hard, painful finger joints are classic for osteoarthritis. In the proximal interphalangeal joints, the PIP joints, they're referred to as Bouchard's nodes, and the DIP joints, the distal interphalangeal joints, they're referred to as Heberden's nodes. The systolic ejection murmur, it's a crescendo decrescendo. So what's happening during systole, you're emptying out your ventricles. So when your ventricles are emptying, blood should be flowing through your aorta and pulmonary valves. And so if you have stenosis of either of those, that's going to cause a systolic ejection murmur. A regurg murmur would be in the mitral tricuspid areas during systole, but this particular murmur, systolic ejection murmur, is there's a period where it is not there because of the isovolumetric contraction period. The heart begins to contract, so systole begins, but the valve doesn't open quite yet. It's not until the intraluminal pressure inside the heart exceeds that of the aorta. So what I'm getting at here is the regurg murmurs of mitral and tricuspid regurg are heard earlier on in systole, and aortic and pulmonic regurg is heard later on in systole. And we'll talk about that again in cardiology. Thyroid cancer with parathyroid cancer and adrenal tumors. Specifically, the thyroid cancer is a medullary thyroid cancer, and then parathyroid and the adrenal tumor classically is a pheochromocytoma, but you can get other types of adrenal tumors. This is a Sippel syndrome, which is the multiple endocrine neoplasia 2A, MEN2A. Ulcerated genital lesion with exudate that is painful is a chancroid caused by Haemophilus ducreyi. What is the painless ulcer? That's the chancre of syphilis, right? Unilateral facial drooping, seen with Bell's palsy. It's a facial nerve palsy. It's a lower motor neuron lesion. Specifically, it's drooping of the entire facial nerve region. The upper portion of the face and the lower portion of the face is classic. If you have just drooping of the lower portion of the face, that would be an upper motor neuron lesion. We'll talk about why that is another day. But one other thing I want to mention here is if you have bilateral Bell's palsy, facial nerve paralysis on both sides, I want you to think about two things. Could be Guillain-Barré, which is the ascending muscle paralysis, can get all the way up to the head and face. The other thing it could be is Lyme disease caused by Borrelia burgdorferi. Moving on, urethritis, conjunctivitis, arthritis in a male. So this is a can't see, can't pee, can't climb a tree with Reiter syndrome. It's one of your HLA-B27 disorders, which are your seronegative spondyloarthropathies. They're called seronegative because the rheumatoid factor is not elevated, even though this looks like kind of like a rheumatoid arthritis. And remember, PAIR was a mnemonic for those disorders, P-A-I-R. The P was for psoriatic arthritis, A was for ankylosing spondylitis, I was for inflammatory bowel disease arthritis, and R was for Reiter syndrome. Vascular birthmark, that's the port wine stain, does not regress with age. You're born with it, sticks with you for the rest of your life, is the hemangioma. This is a bit confusing because hemangioma can mean different things to different people, but the one we're talking about here, the port wine stain, just to clarify, is the one that sticks with you for the rest of your life. And you may have also heard of a strawberry hemangioma, and those strawberry hemangiomas are the ones that might get worse for a couple months, but then they get better over several months to a year or two. But both of them are both benign. The port wine stain is associated with Sturge-Weber syndrome. What is Sturge-Weber syndrome? If you have a port wine stain in the ophthalmic division of your trigeminal nerve, that could suggest an underlying vascular formation intracranially. So you're going to get lots of things like seizures and mental retardation and neurologic disorders associated with that. It's the port wine stain in the ophthalmic division of the trigeminal nerve is associated with Sturge-Weber. Vasculitis from exposure to endotoxin causing glomerular thrombosis is the Schwartzman reaction, followed by a second exposure to endotoxin. Vomiting blood following the esophagogastric lacerations. So you're just retching so much that you lacerate your esophagus. And because then you start throwing out blood, you start bleeding in your esophagus or in your stomach. That is called a Mallory-Weiss syndrome. Classic for alcoholics, eating disorders, classic in those eating contests where you eat 100 hot dogs. Those patients get Mallory-Weiss syndrome. Don't confuse this with something similar, which is Borave syndrome. Borave syndrome is where you completely rupture your esophagus. It's through and through. Your entire esophagus just ruptures. The Mallory-Weiss is just a laceration in the inner layer of your esophagus. One is life-threatening, the other is very concerning. The Mallory-Weiss is very concerning. Can cause severe problems, but not nearly as life-threatening as Borave syndrome. Waxy casts with very low urine flow. So your renal tubules make a waxy substance, and so if there's not much urine going through your renal tubules, that waxy substance is going to build up and form a cast inside there, and then eventually it's going to get flushed out, and so that waxy cast indicates low urine flow or stasis of urine, which is what you would see in chronic end-stage renal disease. White blood cell casts in urine are classic for acute pyelonephritis, infection in your tubules, infection in your kidneys, buildup of white blood cells that also then get eventually flushed out, and the cast is just the outline of the tubule. Now in cystitis, which is a bladder infection, you're going to have white blood cells, but you're not going to have casts. All right, so this is a typo here. White blood cell casts in the urine are not seen with cystitis, the bladder infection. They are seen with pyelonephritis. But in either case, both pyelonephritis and cystitis, you're going to see white blood cells in the urine, just not white blood cell casts. You wouldn't see that in cystitis. Weight loss, diarrhea, arthritis, fever, adenopathy, seen with Whipple's disease caused by Trophorema whippili. We'll talk about that in GI. And worst headache of my life is associated with bleeding in the brain, right? Your meninges being irritated by blood. And the most subarachnoid hemorrhage is what we're talking about here. So subarachnoid hemorrhage. So this also I would consider a typo because you can have a Barry aneurysm that's not causing a headache, right? Barry aneurysms just stay there. They don't really cause problems until they start bleeding or until they start compressing things. Worst headache in my life, subarachnoid hemorrhage. But what's the most common cause of subarachnoid hemorrhage? Barry aneurysm. And Barry aneurysm is associated with lots of different things, including adult polycystic kidney disease. All right, let's go ahead and go through our neuro for today. Our neuro for today is, you can find it on the last page of your psychology and psychiatry section of your handout. It is also in the neuro section of your handout later on, but since we've covered psych today, I just put it on the last page of this section. And it's the brainstem and labeling the brainstem. So very high yield, 4-star topic. It's highly likely that they're going to receive an image of a brainstem, whether a cartoon image or a gross image, or probably a gross image, and they'll point to a cranial nerve and they'll ask you to identify what the cranial nerve is, or they'll ask you to identify, what happens if you lesion this cranial nerve, and they'll point to a specific one. So being able to answer that question means you need to be able to label the cranial nerves as they come off the brainstem. So sorry to say that this is high yield for step 1. So let's get to it and make sure you guys learn these. So on page 8 of your psych handout, we're also looking at page 411 of first aid is another location you can find this information. So number 1 on page 8 of your psych handout. So what is structure number 1 is your pineal body. What does your pineal body make? Makes melatonin, right? Structure number 2 is your superior colliculi. And structure number 3 is your inferior colliculi. Now let's talk about those structures real quick. On page 411 at the very bottom, where it says brainstem dorsal view with the cerebellum removed. You see these structures: pineal body, superior colliculi, inferior colliculi, and look towards the bottom of the page. Your pineal gland secretes melatonin, regulates your circadian rhythm. So we talked about that in behavioral science already. Your superior colliculi is your conjugate vertical gaze center, and your inferior colliculi is auditory information. And the way you can remember that, like it says in the margin, your eyes are above your ears, and the superior colliculus is above the inferior colliculus. So in other words, visual information is in the superior, auditory information is in the inferior. Visual, auditory, just like your eyes are higher than your ears, your superior is visual, inferior is auditory. So it makes it easy to learn. Your Paranod syndrome, not incredibly high yield, but worth learning and worth looking at, is paralysis of the conjugate vertical gaze due to lesion in the superior colliculi. Like a pinealoma, a tumor of the pineal gland can compress the superior colliculi and cause this Paranod syndrome. All right, so let's talk about some other structures on page 8 of your psych handout. Structure number 4 is your optic tract. Structure number 5, coming out from the inferior aspect of your inferior colliculi, is your trochlear nerve. That's cranial nerve 4, your trochlear nerve is the answer to number 5. Number 6, what's that big honking nerve coming off the pons there? That's your trigeminal nerve, cranial nerve 5, your trigeminal nerve. Number 7, coming out inferior to the pons or just lateral to the pons, number 7 is your vestibulocochlear nerve, which is cranial nerve 8. What's labeled as number 8 there is your facial nerve, which is cranial nerve number 7, facial nerve. And what's labeled as number 9 on this image, coming out from the posterior aspect of the olive, is actually two sets of nerves there. Your glossopharyngeal nerve, which is cranial nerve 9, and your vagus nerve, which is cranial nerve 10. And then coming out anterior to the olive, labeled as number 10 there, is your hypoglossal nerve, which is cranial nerve 12. Hypoglossal is cranial nerve 12. And then inferior to that, the last one and the most inferior nerve in the brainstem, the most inferior cranial nerve of the brainstem is your spinal accessory nerves. That's the answer to number 11. Your spinal accessory nerve, which is cranial nerve number 11. All right, what's labeled as number 12 there is your olfactory tract, your olfactory nerve. Number 13 is your optic chiasm. Your optic chiasm, which is where your optic tract comes apart. And so the optic chiasm, just make a mental note here that you see is right up against the pituitary stalk. So if you have a pituitary adenoma, it can compress the optic chiasm and cause that bitemporal hemianopsia, loss of the bilateral visual fields. So that is number 14 is the pituitary stalk. Number 15 is the mammillary bodies. Number 15 is the mammillary bodies. So if you have a lesion to the mammillary bodies, what disease is that? It's Wernicke-Korsakoff syndrome, right? It causes Wernicke-Korsakoff. Thiamine deficiency results in atrophy of the mammillary bodies. Number 16 is your oculomotor nerve, cranial nerve 3. Number 17 is your trochlear nerve, cranial nerve 4. Number 18, again, that large nerve coming out from the pons is your trigeminal nerve, which is cranial nerve 5. And then number 19 here on this diagram is your abducens nerve, cranial nerve 6. So your abducens nerve is coming out inferior to the pons. It's the most anterior of these sets of nerves. And then going just lateral, you have you have the answer to number 20, which is your facial nerve. So number 20 is your facial nerve, which is cranial nerve 7. Number 21, even more lateral, is your vestibulocochlear nerve, which is cranial nerve 8. Skipping down to number 22 there, again, anterior to the olive, we have your hypoglossal nerve, which is cranial nerve 12. Number 23, posterior to the olive, but superior. Number 23 is your glossopharyngeal nerve, which is cranial nerve 9. Number 24 is your vagus nerve, cranial nerve 10. And then number 25, the inferior most one, is your spinal accessory nerve, cranial nerve 11. So again, I know it's a bit cumbersome, but you got to be able to label these, so make sure you know how to do that. All right, let's go back to microbiology again, starting on page 150, and talk some more about bacteria. And let's finish the section on bacteria. We talked about gram-positives, we talked about gram-negatives. Now let's talk about organisms that do not gram-stain. So starting with mycobacteria on page 150. So what are your different mycobacteria species at the bottom of page 150? Of course, you have Mycobacterium tuberculosis. It says causes TB, often resistant to multiple drugs. You guys know that. TB symptoms include fever, night sweats, weight loss, and hemoptysis. You see that in the image in the margin on the right. So if you're screening for TB, those are the questions you're going to ask the patient. Homeless patient comes in with a cough. Are you having any fever? Are you having any hemoptysis, any bloody cough, any weight loss, any night sweats? Those are your TB screening questions. It mentions image 2 there. Let's take a look at that. So this is on image page 1, image number 2. There's lots of different images of TB here. So let's just go ahead and take a look at these real quick. So image 2A. You have these caseating granulomas and Langerhans giant cells. So what you see in this image is a giant cell with a horseshoe pattern of nuclei. Now, if you were to have just this image on your test, all you would really know is this is a giant cell, and you wouldn't necessarily know this is Mycobacterium TB that caused that, but it's something you would think about. Image 2B, you see the acid-fast stain, the red color. So red snappers is a euphemism that they mention here. And then image 2C is a miliary tuberculosis. It's called miliary because miliary is like, grain-like. So it's like it grows in sort of a grain-like appearance. You see that here in the left medial upper lobe of the lungs here. So that can disseminate everywhere in the body, right, and cause a miliary TB. So let's talk a little bit more about tuberculosis on page 150 at the very top, primary and secondary tuberculosis. So you're exposed to tuberculosis, top of the diagram here. One of two things happens. Non-immune host, like a child, gets primary TB. Primary TB can have lots of downstream effects. You have the hilar lymphadenopathy. Gone focus is in the lower lobes. So what is a gone focus? A gone focus is a calcified scar. So the calcified scar in the lungs due to TB is a gone focus. When you have a calcified scar in the lung and then hilar calcification, hilar lymphadenopathy or hilar calcification combined with that calcified scar in the lungs, that is a gone complex. Make sure you know the difference between a gone focus and a gone complex, and make sure that you can recognize that as tuberculosis, that calcified scar. We're not talking about caseating granulomas yet. We're talking about calcifications in the lung. So what else can happen with primary TB the first time you're exposed to TB? On the left, you have healing by fibrosis, immunity, and hypersensitivity. Tuberculin positive, what is that? It's your PPD skin test. So you do a PPD skin test. Look a little bit further down the page. If you're PPD positive, it's going to indicate a few different things. Either that you're currently infected. Do you currently have disease? Not necessarily, but you're currently infected. It could indicate a past exposure that you've recovered from, or that you've been vaccinated. All the PPD says is that you have an immune response to tuberculosis. So that could have been brought about by the BCG vaccine, which we do not give here in the U.S., but is commonly given in other countries. The problem with the BCG vaccine is it's not 100% effective. And once you've been vaccinated, you can't determine whether or not you have tuberculosis. So here in the U.S., we choose not to BCG vaccinate so that we can detect very easily when somebody has tuberculosis, especially given the vaccine is not incredibly effective. Now, one thing to know about the BCG vaccine, and pretty much any vaccine, is as you age, your immunity to that particular vaccine or that particular organism starts to wane. So you need to know that you have impaired memory function. Your memory B cells that were stimulated with the vaccine start to die off as you get elderly. And so as somebody that was BCG positive because of was PPD positive because of the BCG vaccine in their 40s may not be BCG positive in their 80s. All right, and if you're PPD negative, indicates there's no if there's no infection, or if you're anergic. Basically, if you cannot generate an immune response, you're not going to be PPD positive, right? So patients on steroids, they might have tuberculosis, but they don't have an immune response to your PPD test. Malnutrition, immunocompromised states, and sarcoidosis. These are all things that can lead to a falsely negative PPD test. What is PPD anyway? It's purified protein derivative. All right, so what else can happen with tuberculosis, primary tuberculosis? We looked at the left-hand side of the diagram. Just to the right of that is progressive lung disease, which you might see in a patient with HIV, malnutrition, an immunocompromised patient here, and that's going to cause death. So it's very rare. It's not the most common thing that happens, but it can happen. You can have severe bacteremia, causing the miliary tuberculosis, which we saw an image of earlier, the grain-like spreading of the disease, and that can cause death. And then on the far right, you have pre-allergic lymphatic or hematogenous dissemination that results in a dormant tubercle bacilli in several organs that can then reactivate in adult life. Just as an FYI, any idea how much of the world has been infected at some point with tuberculosis? It's actually 1/3 of the entire world has had tuberculosis at some point in their life. And all of those have dormant tuberculosis. They've been infected, but either they've developed immunity, or the more common scenario, the most common scenario with TB is you have this dormancy of the bacilli in several organisms. So you're PPD positive, you are infected, but you do not have the disease. It's not rampant. It's not manifesting. What is the lifetime prevalence of that 33% of the worldwide population? What's the lifetime prevalence that they will go on to develop disease, that those dormant tubercle will start to spread and become rampant? It's about 5 to 10%. About 5 to 10% will develop the active disease. TB is very clinically relevant to us here in the U.S. Specifically in the last 20 years. There was a worldwide decline, a U.S. decline in tuberculosis for a number of years until HIV came about. When HIV came about in the 80s, tuberculosis came back onto the scene again. And the reason why is because if you have HIV, you're 100 times more likely to acquire tuberculosis. And there are other risk factors too. If you have diabetes, you're 3 times more likely to acquire TB. So anything that can, impair your body's ability to heal itself is going to increase your likelihood of acquiring tuberculosis. Well, what is the secondary tuberculosis? On the right-hand side of this diagram, at the very top, you have a partially immune, hypersensitized host, usually adults. So most of these patients are patients with dormant tubercles. You have reinfection or reactivation. They don't have to be exposed to it again. They can be exposed to it again within their own body. That's a reactivation of these dormant tubercles. That's secondary tuberculosis, and that's when you get your fibrocaseous cavitary lesions, your caseous granulomatous lesions. It's the only granuloma where you have this cheese-like caseous necrosis is with tuberculosis. We've seen lots of different granulomatous disease, but tuberculosis is the only one that has caseous granulomas. Caseating granulomas. And that can cause reactivation tuberculosis in the lungs, which can cause extrapulmonary tuberculosis. And it's those fibrocaseous cavitary lesions that cause the hemoptysis and the lung disease. But what are the extrapulmonary tuberculosis? You can have CNS lesions, which you would be able to detect with CSF analysis. And it can cause parenchymal tuberculoma, in the brain parenchyma and your gray matter. It can cause meningitis. You can have a TB meningitis, actually fairly common. TB in your vertebral bodies causes Pott's disease. Note that that's in bold. That's something that you want to be able to identify in your tests. Lymphadenitis, renal disease, GI disease, that miliary tuberculosis. Once TB spreads, it can go everywhere. It's one of the great imitators. It can cause lots of different manifestations of disease. Okay, so that's pretty much it for tuberculosis. Let's move on and talk about some other mycobacteria towards the bottom of page 150. So Mycobacterium kinsaci causes pulmonary TB-like symptoms. This is particularly prevalent in patients with chronic bronchitis or emphysema. So it's clinically relevant in patients with COPD. The next one, Mycobacterium avium intracellulare. Sometimes this is also referred to as Mycobacterium avium complex. The other abbreviations for this are MAI or MAC. So MAC or MAI is often resistant to multiple drugs, causes disseminated disease in AIDS patients. And the last thing it says there's all mycobacteria are gram-positive acid-fast organisms. So Mycobacterium as a species as a whole, they stain with acid-fast. They are weakly gram-positive. They're much harder to identify with gram stain. One other thing I was going to mention here is they're very slow-growing organisms, and because they grow so slowly, they're very difficult to culture, and it takes 2 to 4 weeks to culture Mycobacterium. And what kind of agar do you need to culture Mycobacterium? It's a Lowenstein-Jensen agar. Lowenstein-Jensen agar to culture Mycobacteria. It takes 2 to 4 weeks. So if you have a patient coming in with cough, hemoptysis, night sweats, cavitary lesions, you really suspect they have TB, you're not going to wait 2 to 4 weeks for the culture to come back to confirm it. So how do we confirm TB? You do an acid-fast stain every morning on the sputum. So you have the patient, 3, 4, 5 a.m., cough up some sputum. You do an acid-fast stain on that sputum 3 days in a row. Has to be an early morning sample. And if that's negative, then it's probably not the case that they have TB. If one of those is positive, then you have your diagnosis of TB. If it's negative, you can discharge them from the hospital. They can go home, but you still need to make sure that you follow with a culture eventually when it does come back. There are a few other Mycobacterium species. Let me just mention a couple of them, not incredibly high yield, but just for completeness sake, there's Mycobacterium scrophulacum, which causes a cervical lymphadenitis in children, particularly. There's also another Mycobacterium called Mycobacterium marinum. So marinum, what does that make you think of? Like mariners, like water, and this is an aquatic associated Mycobacterium. So you're going to see this in patients that work in shipyards, patients that like to boat. And then one other unique scenario is if you have a lesion on your hand and you're dealing with an aquarium, that can also cause an infection of Mycobacterium marinum, so aquarium handlers. So usually it's just a superficial skin infection, but can also cause deeper skin infections, can cause osteomyelitis, which is an infection of the bone, and can cause even arthritis and can get deeper. So one also to be aware of Mycobacterium marinum. Okay, let's go to the next page. Let's talk about Mycobacterium leprae, which causes leprosy. The other name for leprosy is Hansen's disease. Acid-fast bacillus, likes cool temperature, infects the skin and superficial nerves, cannot be grown in vitro. Reservoir in the United States is armadillos. And one of the reasons why is because armadillos have very cool pads, and Mycobacterium leprae likes the cool pads, resides in the cool feet pads of the armadillos. So in the margin there it says Hansen's disease has 2 forms, leprotomus and tuberculoid. So it says a leprotomus presents diffusely over the skin and is communicable. It's a failed cell-mediated immunity, so that's the one that's contagious. And then the tuberculoid is limited to a few hypoaesthetic nodules. So let's look at image page 3. Image number 14, you see leprotomus leprosy. Again, that's the one that's communicable, that's spreadable. You have nodules and thick plaques on the dorsum of the fingers and wrists. So this is, classically what you think of with leprosy. Now, the other thing with leprosy, like it said here, is it's an infection of the superficial nerves, and so because of that, you lose sensation to your digits and sensations to your feet and your hands. And the reason why that's clinically relevant is patients with leprosy will, they'll injure their hands or their feet and not know it. And that's one of the reasons you have such disfigurements with leprosy. It's the chronic recurring injuries that end up disfiguring these patients. How do we treat this? Long-term oral dapsone can be used. Toxicity with dapsone is hemolysis, particularly if you're G6PD deficient, glucose-6-phosphate dehydrogenase deficient. You're sensitive to oxidizing drugs like dapsone. We'll talk about that a few other times. And then also oral dapsone can cause methemoglobinemia, which we'll talk about another day. Alternative treatments, if you do have G6PD deficiency, what else can you use? You can use rifampin, you can use clofazimine and dapsone. Use all three of those. It's a 3-drug combination. Tuberculosis is hard to treat. Mycobacterium is hard to treat. So you have to use lots of drugs for TB. You have to use lots of drugs for leprosy. Rifampin, clofazimine, and dapsone. And because Mycobacterium is slow growing, you have to use this regimen for 6 months to 2 years. All right, a very long regimen. One other thing I want to mention about dapsone, another clinical scenario you're going to see dapsone being used is in PCP pneumonia, the pneumocystis jirovecii pneumonia that HIV patients or AIDS patients commonly get. You can use dapsone for that also. So just think about those two uses for dapsone, for leprosy and for PCP pneumonia. Let's talk about your spirochetes on page 154. So it says here there's, spirochetes are spiral-shaped bacteria, axial filaments. They include Borrelia, which causes, Lyme disease, Borrelia burgdorferi. We'll talk about that in a second. Leptospira, which we'll also talk about in a second, and Treponema. They can be visualized using aniline dyes like Wright stain or Giemsa stain in light microscopy. And then Treponema, which causes syphilis, Treponema pallidum, you use dark field microscopy. So let's talk about Leptospira first. Leptospira, like I said, is question mark shaped bacteria. You can see that in this drawing that they have. You can also see it in this particular image that we have. This is an image of spirochetes on a blood smear. So you can see that these definitely have a very characteristic shape to them. The other thing it says about Leptospira here is water contaminated with animal urine. Definitely know that. If you see an infection associated with animal urine, I want you to think of 2 types of infections. The first one is Leptospira. The second one is associated with rodent urine or rat urine or mice urine is hantavirus. We'll talk about viruses another day, but Leptospira and virus are both associated with animal urine. So what is leptospirosis? You have flu-like symptoms, fever, headache, abdominal pain, jaundice. Not a lot of infections cause jaundice. Here is one that causes jaundice, photophobia with conjunctivitis. So everything else is pretty non-specific. A lot of your viruses cause these flu-like symptoms, headache, fever, abdominal pain, but jaundice is unique with Leptospira. So urine, jaundice, think about Leptospira. Prevalent in the tropics. We really don't see Leptospira much in the U.S., if ever. Can also cause Weil's disease, which is an like icterus, jaundice, ictohemorrhagic leptospirosis. So you have jaundice, azotemia. What is azotemia? It's elevations of your BUN and creatinine indicating renal disease. So again, liver and kidney dysfunction is what we're talking about here. And the ictohemorrhagic, so the hemorrhage also with anemia, fever. So this is hemorrhagic disease, is Weil's disease. Let's move on to Lyme disease next. What causes Lyme disease is Borrelia burgdorferi. We've mentioned Lyme disease a few times. Definitely clinically relevant for the U.S., especially if you live in the Northeast. Transmitted by the Ixodes tick, which is also the bacteria for Babesia, which is another disease, which we'll talk about another day. You have the erythema chronica migrans. So take a look at this. It's the expanding bullseye rash that's classic for Lyme disease. With central clearing, there's different stages to Lyme disease. Stage 1, the ECM, the erythema chronica migrans, that expanding bullseye rash, and flu-like symptoms. And you don't always have the bullseye rash with Lyme disease, which is why if you live in the northeastern U.S. or you are visiting there and you get bitten by a tick, it might be in your best interest to go ahead and get treated empirically for Lyme disease, even though you don't have the classic bullseye rash. Because you don't want to have the later manifestations of Lyme disease. It can be very problematic. What are the stage 2 manifestations? Now, the stage 2 manifestations usually come about weeks to months after the tick bite, and they consist of, you can have a meningitis, so Lyme's disease can cause meningitis. You can have lots of neuropathic problems. So it mentions Bell's palsy. So you can have a unilateral Bell's palsy, paralysis of one entire side of your face, a facial nerve paralysis, both the lower face and the upper face. Other things you can have is, you can get a bilateral Bell's palsy with Lyme disease. You can have, radicular pain, which is, referred pain, referred neuropathic pain. You can have peripheral neuropathy in stage 2 of Lyme disease, and also mentions the cardiac effects of stage 2. So it mentions AV nodal block, also what's called myopericarditis, carditis, inflammation of the heart, myopericarditis, inflammation of the muscle, the myo of the heart, and the pericardium, the peri of the heart. So myopericarditis can occur with Lyme disease. So to reiterate, stage 2 of Lyme disease can cause meningitis, can cause neurologic problems like unilateral or bilateral Bell's palsy, radicular pain, peripheral neuropathy, and it can cause carditis, including AV heart block and myopericarditis. Definitely know that. All right, Lyme disease, very high yield for your test, at least a 3 or 4 star topic here. Late Lyme disease is stage 3 Lyme disease, occurs months to years after the infection. You can have a chronic monoarthritis, a migratory polyarthritis, so basically arthritis, especially of the knee. You can also have a subacute encephalitis, so can have CNS encephalopathy changes in addition to arthritis. Can be characteristic of late Lyme disease. Very debilitating for your life to have late Lyme disease. So how do we treat Lyme disease? I mentioned doxycycline and ceftriaxone. The doxycycline is your drug of choice for early Lyme disease. Stage 1, stage 2 Lyme disease is doxycycline. For late Lyme disease, you use ceftriaxone, which you might know better as Rocephin. But ceftriaxone is given for an entire month to treat late Lyme disease. And it mentions also in your book here that it's named after Lyme, Connecticut, so again, northeastern United States. Treponemal disease. Lots of different treponemal diseases at the bottom of page 154. Treponema pallidum causes syphilis, which we'll talk about in a second. Let's talk about Treponema pertinue first. Causes yaws, which is an infection of the skin, bone, joints. And then with this one, you have healing with keloids. And those keloids, what is keloid? Keloid is a scar with excess collagen in it. So scarring with excess collagen, if you have that, that can cause limb deformities. The other thing that's particularly common with yaws and Treponema pertinue is facial disfigurement. Facial disfigurement after like 5 to 10 years of infection. So if you treat it early, no big deal. If it goes on for years and years and years, can cause the keloids, disfigurement, and facial disfigurement also. Specifically, the characteristic facial disfigurement of yaws is destruction of the nasal bone and cartilage, so nasal disfigurement. Syphilis, Treponema pallidum is an STD. Yaws, pertinue is not an STD. But it does have a positive VDRL, like syphilis does. Syphilis now on page 155. So again, it's caused by Treponema pallidum. How do we treat it? Penicillin G. Definitely know that. You treat syphilis or primary syphilis with penicillin G, which is the IV or IM form of penicillin, right? But what if you're allergic to penicillin? What do you use? You use that same drug that we use for Lyme disease, a doxycycline. So doxycycline can be used for this also. Think about doxycycline for your spirochete infections. There's different stages of syphilis also. If you don't treat the first stage, you're going to get the second. If you don't treat the second, you're going to get the third. So primary syphilis is a painless chancre and localized disease. You can see this on image page 3. Let's take a quick look there. Image page 3, image number 12A. You see the chancre of syphilis. Now, while we're here, let's take a look at image 12B. This is what's called neurosyphilis, which is a tertiary syphilis, also called tabes dorsalis. So you can see here that your dorsal columns are obliterated. What information is carried in your dorsal columns? Primarily, you have a lot of pain, proprioceptive information in particular. So a lot of sensation information, proprioceptive information. We'll talk more about that, but definitely take note of that image 12B there for syphilis. All right, let's go back to page 155, talk about secondary syphilis. So primary syphilis, painless shaker. Secondary syphilis, you have constitutional symptoms, so fever, chills, things like that. And then you have a maculopapular rash on the palms and soles. We mentioned that's one of the things that causes rash on the palms and soles with secondary syphilis. Also Rocky Mountain spotted fever, and then Coxsackie A virus. All can cause rash on the palms and soles. Condyloma lata. One other thing to throw in there is alopecia areata. What is alopecia areata? It's a patch of complete balding. So complete, shiny bald spot is alopecia areata. If you see a patient with that, you might consider screening them for syphilis, because that can cause that as well. What does tertiary syphilis look like? You have these gummas. All a gumma is the granuloma caused by syphilis. It's called a gumma, all right? Chronic granulomas. Aortitis, so inflammation of your aorta, also referred to as tree barking of the aorta, because the aorta takes the appearance of tree bark, is how inflamed and disfigured it is. Why does it cause this? What is this? It says vasa vasorum destruction. What the heck is a vasa vasorum? Those are the little tiny arteries that supply the tissue of the aorta. Your aorta is a very thick tissue, and it needs its own microscopic blood supply. And that microscopic blood supply, those little capillaries of the aorta, are the vasa vasorum. If you destroy those, you're going to disrupt the tissue of the aorta, right? And then neurosyphilis is tabes dorsalis. So lots of different things can happen with tertiary syphilis. Argyll-Robertson pupil, what is that? So Argyll-Robertson pupil, looked right below there in that next section. The pupil constricts with accommodation. What does that mean? You take the finger, you bring it to the patient's nose, the eyes go midline, and the pupils constrict when the eyes go midline. That's accommodation, as you bring something closer to the face. But it is not reactive to light. So you shine a light in the patient's eye, and almost always it's the case. You shine a light in the patient's eye, you're going to have meiosis, right? Not the case with syphilis. It's referred to as a prostitute's pupil, like it says in the margin, because it accommodates but does not react, just like a prostitute. So not very PC, but it makes it easy to remember. All right, let's talk again about the tabes dorsalis. So we saw that image where your dorsal columns are destroyed. You have impaired proprioception. So because you have impaired proprioception, you do not know where your limbs are in the world. If you're not looking at your legs, you don't know where your leg is. If you're not looking at your arms, you don't know where your arms are. So because of that, look at the signs of tabes dorsalis in the margin there. Broad-based ataxia. All right, you don't know where your legs are, so you have a wide gait, and you're not able to walk very well because you don't know where your legs are. Positive Romberg sign. What is the Romberg sign? It's where you have the patient stand with their feet together, right? Have them put their arms out. You have them close their eyes. What the heck are you doing there? All right, what is the Romberg test? Let's just talk about that real quick. Little neuro snippet here. So the Romberg test, there's three things. There's three things with the Romberg test. There's three things that allow you to know where your body is in the world, to know that you're standing upright. There's three pieces of information. Your vision tells you if you're upright or sideways or upside down. Your proprioceptive information tells you where your body is in the world, and your vestibular apparatus in your inner ear tells you, your otoliths, those little stones in your inner ear, tell you where your body is in the world. So you need two of those pieces of information, two of those three pieces of information need to be intact in order for you to know where your body is in the world. So if you spin around really fast, you're going to mess up your vestibular apparatus. All right. Now, if you have an excellent proprioception and you're looking, you're still going to be able to stand up. But if you spin around really fast and close your eyes, you're going to fall right down, right? Because you just lost two pieces of information. So what are we doing with the Romberg test? You have the patient stand there and you have the patient close their eyes. All right, you're taking away the visual information. So all that's left is vestibular apparatus and proprioceptive. What if you don't have proprioceptive information? Because you have syphilis, you're going to fall down. Why do we have their arms forward? That way you can predict where they're going to fall. The arms forward is just to have that prediction, to put them off balance in a predictable way. So the Romberg information is testing two things. It's testing your ability to perceive, propriocept, where your body is in space, and it's also testing your vestibular apparatus. If either one of those is dysfunctional when you close your eyes, you're going to fall. It is not, the Romberg test is not a test of your cerebellum. All right, it's a very common perception in medical students that the Romberg tests the cerebellum. It does not. It tests proprioception and it tests your vestibular apparatus. All right, moving on. Charcot joints. Charcot joints are very damaged joints, joints that get damaged because you don't know where your joint is in space. You can't feel your joint. You can't feel the pain in your joint. So you might have your joint in a very awkward position. You might be, sitting on your knees, or you might have your legs crossed and your knees in a very strange position, causing damage to your joint, but you don't know that you're causing damage to your joint. You don't feel that pain. So you have chronic joint damage as a result of that. Charcot's joints are very uncommonly caused by syphilis nowadays because we really don't see much tertiary syphilis like they did in the 1800s. So what causes Charcot's joints nowadays is diabetic peripheral neuropathy. Is the most common cause of Charcot's joints. And then stroke without hypertension can also be seen with tertiary syphilis. All right, so that's tertiary syphilis. Congenital syphilis. Mom's pregnant and acquires syphilis. What does the fetus look like? It mentions a few things in your book. Saber shins, saddle nose, are a couple things here. So what are saber shins? Let's talk about these in turn. So saber shins is an anterior bowing of the tibia. And by the way, these are what's called the late manifestations of congenital syphilis. If you know a newborn has syphilis and you treat them very early on, they will not get those late manifestations of syphilis. But take a look at this slide here. What are the late manifestations of congenital syphilis? Hutchinson teeth is one that's not in your book. I guess it is in your book, yeah. So Hutchinson's teeth is notching of the upper incisors. Your upper incisors normally come to 1 point. If your incisors have 2 points because there's a notch in the middle, that's Hutchinson teeth. Saddle nose deformity is a flattening of the nasal bridge or a collapsed nasal bridge. Frontal bossing is another thing you can see with late congenital syphilis, and the saber shins, again, are anterior bowing of the tibia. So it's a tibial malformation due to a late syphilis. And again, you're not going to acquire these things if you treat the syphilis early in the newborn. So what are the early signs of syphilis? What happens when a newborn has syphilis? What types of things would you see? One thing that's useful to know is what's called snuffles. Blood-tinged nasal secretions or snuffles that you see with early syphilis. And if you can identify that and treat it, they will not acquire the late manifestations of congenital syphilis. All right, that's pretty much it for syphilis. Let's talk about your VDRL test versus FTA-ABS. The FTA-ABS is more specific for treponemes, turns positive earliest in disease, and remains positive the longest. So we usually screen with VDRL, or the other test is called an RPR. So VDRL or RPR is used for screening, and in most institutions, the FTA-ABS is used for diagnosis. So if the VDRL is positive, your FTA is positive, active infection. All right, VDRL positive, FTA is negative, possibly false positive. If the VDRL is negative and FTA is positive, often that indicates a successful treatment. Now, one caveat here is that the VDRL does not have 100% sensitivity or specificity. So sometimes your VDRL is negative and your FTA is positive, and those patients are infected also. So you need to make sure that if either of those are positive, that the patient has received adequate treatment with penicillin G, right? That's how we treat this. Alternatively, if they're allergic, you use what? Doxycycline. So let's talk about false positives for VDRL. So there's a few things. In the margin there, it says there's a great mnemonic for viruses, including mono. What causes mono is Epstein-Barr virus. And also hepatitis can cause a false positive VDRL. Drugs, rheumatic fever, lupus, and leprosy can all cause a false positive VDRL. What is it? It mentions in the first sentence there, it's a nonspecific antibody that reacts with beef cardiolipin, used for diagnosis of syphilis, but again, other things can elevate it and cause it to be falsely positive. So definitely be aware of that, which is why we do the FTA-ABS test if you are positive, to make sure you're not dealing with a false positive. All right, let's look at page 156 now and talk about Gardnerella vaginalis. Now, Gardnerella vaginalis causes something called bacterial vaginosis. You will see this, incredibly clinically relevant. You see this all the time. It's very, very common. Like it says, it commonly presents as a gray vaginal discharge with a fishy smell and is not painful. It's not like the Haemophilus ducreyi, or it's not like herpes. You don't have a lesion; it's just vaginal discharge. Mobiluncus, it says, is an anaerobe, is usually involved. But one thing to know about Gardnerella, it's a polymicrobial infection. All right, it's lots of different microbes coming together causing this infection, one of which is Mobiluncus, but it's polymicrobial. It says it is associated with sexual activity, but not an STD. So what the heck does that mean, right? So it can be an STD, all right? This can be spread by sexual transmission, but it can also be spread by non-sexual transmission. So some women just acquire this not by sexual means, and that's what that sentence is saying. It can be an STD, but can also be acquired by non-sexual means. Bacterial vaginosis, you have overgrowth of certain bacteria in the vagina, and this causes a clue cells. What is a clue cell? The clue cell is a vaginal squamous cell that's just covered with bacteria. Take a look at image page 3. Image page 3, image 13 is bacterial vaginosis, and you see the dark clue cell in the middle there. Look at the other, smooth edges of these other squamous cells. And then you see this one in the middle has these very ragged edge. That raggedness of the edge of the squamous cell is all those bacteria around the outside. So if you see a squamous cell that does not have a smooth edge, but rather a very ragged edge, that is a clue cell diagnostic of bacterial vaginosis caused by Gardnerella vaginalis, Mobiluncus, and other polymicrobes. How do we treat it? Metronidazole. All right, you can use a metronidazole cream or metro gel, or you can give oral metronidazole. Okay, so let's move on to rickettsia next. So rickettsia do not gram stain because they are obligate intracellular parasites or obligate intracellular organisms. There's what's called the rickettsial triad. Most all rickettsial organisms cause a syndrome of headache, fever, and rash. That's called your rickettsial triad. Coxiella is the only exception, and we'll talk about that as an exception in just a second. So how do we treat most all rickettsial infections? Is tetracycline. So what are your rickettsial diseases? It's the next section down there. There's Rocky Mountain spotted fever caused by Rickettsia rickettsii. Let's skip down another section and talk about Rocky Mountain spotted fever. Symptoms: rash on the palms and soles. We've seen this before. Coxsackie A virus, secondary syphilis, Rocky Mountain spotted fever, rash on the palms and soles. And then again, your rickettsial triad, headache, fever, rash. It's endemic to the East Coast, not so much the Rocky Mountains, all right, more the Appalachian Mountains and the East Coast. One other thing, it mentions the rash on the palms and soles, and you see that in the margin there, Coxsackie and syphilis and such. I also want to just throw in there peeling of the palms and soles. If you have peeling of the fingertips, peeling of the hands or the soles of the feet, I want you to think of two other things, all right? It could be something called acrodynia. Acrodynia is the manifestation of peeling of the palms and soles due to mercury intoxication. We'll talk about mercury another day. But the other thing that can cause that is Kawasaki disease. All right, so we've talked about two things so far with Kawasaki's disease, which is a vasculitis. We've talked about strawberry tongue, and now we've talked about peeling of the palms and soles. Okay, so that's pretty much it for Rocky Mountain spotted fever. All right, let's talk about other rickettsial diseases. So back up to that section of first aid, in the middle of first aid. Endemic typhus caused by fleas is caused by Rickettsia typhi. And then epidemic typhus is transmitted by the human body louse or lice, caused by Rickettsia prowazekii. What is the difference between an endemic disease and an epidemic disease? All right, terms worth knowing. Endemic means it exists in the population, all right? It exists constantly in a population. And an epidemic is a very sudden onset in the population. Take a look in the margin. It says that rickettsial rash starts on the hands and feet. Typhus rash, caused by Rickettsia typhi, starts centrally and spreads outward without involving the palms or soles. So rickettsia on the wrists, typhus on the trunk. All right, so that's a nice little clue for you. Ehrlichiosis is caused by a tick as the vector. Ehrlichia causes that, not that high yield for step 1. Q fever is caused by inhaled aerosols caused by Coxiella burnetii. All right, so here's the thing. Coxiella burnetii causes Q fever, and like it says in the margin, this is queer. All right. Why is Coxiella and Q fever queer? It's queer because it's unique to the other rickettsial diseases. How is it unique? Like it says in the margin, there's no rash with Q fever. So what do you have with Q fever? You have fever and interstitial pneumonia. All right, so fever, interstitial pneumonia. There's no vector. So all these other rickettsial diseases have a lice or a tick or fleas. There's some vector. With Coxiella, there's no vector. It's spread by aerosol transmission. There's a negative wheel felix. We'll talk about that in just a second. And its causative organism can survive outside for a long time. Why do you think that is? Why can Coxiella burnetii survive outside for a long time? Because it's a spore former, right? Like Clostridium and like Bacillus. And the other thing that makes Coxiella queer is it does not have rickettsia in its genus name. All right, so several unique things with Coxiella burnetii. So it mentions that Coxiella has a negative wheel felix reaction. So what is a wheel felix? It's on the bottom of page 156. It says patients with rickettsial infection have antibodies against rickettsia. When patient's serum that's filled with these antibodies against rickettsia is mixed with Proteus antigens, anti-rickettsial antibodies cross-react and agglutinate. They clump together. So that's called a positive wheel felix. It does not do that. That's a negative wheel felix. And we just said that Coxiella does not have a positive wheel felix. All the other rickettsial infections have a positive wheel felix reaction because you develop antibodies. The last thing, pretty much all these rickettsial disease, how do we treat it? Tetracycline. So use tetracycline for rickettsial diseases. Let's go to the next page, talk about chlamydia, which is also primarily intracellular, right? Remember, rickettsia, chlamydia, they're intracellular because it's really cold outside. So there's different chlamydia organisms. We're going to talk about these each in turn. The first one is actually in the margin. All right, let's talk about this one. Chlamydia psittaci is notable for an avian reservoir. All right, do not discount this fact. All right, high yield. Important to know about Chlamydia psittaci. There's a reason why they put it in first aid. It causes what's called psittacosis. All right, this is a lung disease that can spread systemically. And it's found in an avian reservoir. So if you have a patient that presents with a severe, life-threatening lung disease that has a pet parrot at home, think about Chlamydia psittaci. All right. Anytime you see Chlamydia psittaci, there's going to be some type of bird associated with it in a question stem. So just tie those two together. Psittaci, birds. So the next chlamydia organism we're going to talk about is Chlamydia pneumoniae, which is towards the bottom of that chlamydia section. It says Chlamydia pneumoniae and Chlamydia psittaci cause atypical pneumonia transmitted by aerosol. So let's just, we talked about Chlamydia psittaci. Let's highlight Chlamydia pneumoniae now. Chlamydia pneumoniae is one of three organisms. This is not an STD. It's one of three organisms that causes interstitial or atypical pneumonia or walking pneumonia. Three terms that can be used interchangeably. Interstitial pneumonia, atypical pneumonia, walking pneumonia, caused by three different organisms. We've talked about one of them already, which was Legionella pneumophilia. Here's a second one, Chlamydia pneumoniae, and the third one, the most common one, is Mycoplasma pneumoniae, which is at the bottom of this page. We're going to talk about it in just a second. So those are your atypical interstitial pneumonia. Just FYI, talks a little bit more about this on page 512 of first aid. So you might just make a note of that. This is transmitted by aerosol spread. How do we treat these infections? Erythromycin or tetracycline. So tetracycline works for rickettsia, tetracycline works for chlamydia. Let's talk about next Chlamydia trachomatis. So it mentions in this section here you have a reactive arthritis, conjunctivitis, urethritis, pelvic inflammatory disease. Let's skip down towards the bottom of the page where it says Chlamydia trachomatis serotypes. So there's different serotypes here. Types A, B, and C causes chronic infection, specifically a chronic eye infection called trachoma. It causes blindness in Africa. All right, so not particularly common in the U.S. Don't really need to know it so much for the USMLE. Again, this is a test for licensing of the United States. So most infections that are not present in the United States are not highly testable on the USMLE. All right, the things that are highly testable on the USMLE are things that are more common in the U.S. But what are the other Chlamydia trachomatis serotypes? There's types D through K, which basically looks like gonorrhea, right? Urethritis and pelvic inflammatory disease. ectopic pregnancy. Why does it cause ectopic pregnancy? Because you have scarring of the fallopian tubes because of this disease, and so the fertilized egg doesn't make it all the way down to the uterus. Instead, it gets stuck in the fallopian tubes because of the scarring. That's why it causes ectopic pregnancy. Neonatal pneumonia and neonatal conjunctivitis is also caused. So we talked about these already with gonorrhea. So same type of thing. You can just kind of use these interchangeably. Now, one thing with chlamydia is it can be very subclinical, especially in women. 50% of women that have chlamydia do not even know that they have it, unfortunately. So there's, which is why some physicians will advocate whenever you do a pap smear, especially on a young sexually active woman, to go ahead and test for gonorrhea and chlamydia because so much of it is subclinical and because it can have such devastating effects of ectopic pregnancy, which is life-threatening. PID, pelvic inflammatory disease, is also life-threatening. So it is not a task force recommendation, but it is a loose recommendation by some physicians. Types L1, L2, and L3 are other serotypes here cause lymphogranuloma venereum, which is an acute lymphadenitis positive free test. So the free test is actually an outdated test that we do not use anymore. So just ignore that. Don't worry about the free test. It says that don't confuse with granuloma inguinale, which is caused by this other organism, not high yield either, so don't get bogged down with that. One thing I do want you to know about types L1, L2, and L3 and lymphogranuloma venereum is it causes primary ulcers, so it is an ulcerative disease in addition to lymphadenitis. It can cause an inguinal lymphadenitis, lymphadenopathy for 2 to 6 weeks afterwards. So it starts with a primary ulcer and then inguinal lymphadenitis for 2 to 6 weeks. And then one other thing here is it can cause rectal disease. So rectal disease, and one reason why this is clinically relevant is this rectal disease caused by lymphogranuloma venereum is commonly mistaken for inflammatory bowel disease like Crohn's disease or ulcerative colitis. So that's worth knowing. One other thing I'm going to say here is in the margin, it says neonatal disease, like neonatal conjunctivitis for the types D through K serotypes, can be acquired during passage through the infected birth canal. We treat this with oral erythromycin, and another reason why we give erythromycin eye drops to newborns is for the prophylactic treatment of a subclinical or occult gonorrhea or chlamydia infection. And the last bacteria on page 157 is Mycoplasma pneumoniae. Definitely important to know, 3 to 4 star topic here. Very, very common organism. Causes atypical or walking pneumonia. And why is it called walking pneumonia? It's very insidious onset, headache, non-productive cough, diffuse interstitial infiltrate. Normally when you think of pneumonia, you think of a big lobar pneumonia. Patient looks very ill, almost septic, coughing up a bunch of sputum. Walking pneumonia does not look like that. These patients have almost a subclinical pneumonia. They just have a headache, they're coughing, it's non-productive. It's just a cough that they can't get rid of for weeks and weeks. You take an x-ray, and the x-ray looks much worse than the patient's symptoms do. And that's classic for walking pneumonia, interstitial pneumonia, atypical pneumonia. X-ray looks worse in the patient. All right, it also mentions here that there's a high titer of cold agglutinins. What are cold agglutinins? They are IgM antibodies. They can agglutinate or lyse red blood cells only in cold environments. So it's not a problem unless you reach your hand in a refrigerator or you're not wearing gloves on a cold day. That's why they're called cold agglutinins. They do not agglutinate unless they're in a cold environment. How do we treat this? The same way that we treat chlamydia, tetracycline or erythromycin. Commonly and clinically for Mycoplasma pneumoniae, we give azithromycin, which is a different macrolide similar to erythromycin. You might know azithromycin better as the Z-Pak, right? Take a look in the margin there. Mycoplasma has no cell wall, not seen on gram stain. You guys know that already. It's the only bacterial membrane containing cholesterol, makes it unique. Mycoplasma pneumonia is more common in patients younger than 30 years of age and frequent outbreaks in military recruits in prisons. So anytime you have individuals younger than 30 put in groups together on a bus trip, in dormitories, in the military, in prisons, you're going to probably encounter Mycoplasma pneumoniae if all of them start to cough. All right, so that's it for bacteria. Go ahead and take a look at your microbiology handouts. There's a quick quiz over organisms that do not gram stain. Go ahead and go through this quiz, and then we'll go through these answers together, and then we'll move on to finish up antibiotics. All right, let's go ahead and go through the answers. So number one, which rickettsial species has properties unique from others? Is it Coxiella burnetii? What are those properties? Has the negative wheel Felix. The name is different. There's no vector like lice or ticks or fleas. Instead, it's aerosol transmission. Has an endospore that allows it to survive outside for a long period of time. And then there's no rash. It does not have the characteristic rickettsial triad. Instead, it causes an interstitial pneumonia. Number two, what infections are caused by chlamydia? So we talked about chlamydia psittaci causing a pneumonia in patients with birds. We talked about chlamydia pneumoniae causes interstitial pneumonia or walking pneumonia. And we also talked about chlamydia trachomatis. And there's different serotypes. One serotype or one series, types A, B, and C cause a trachoma eye infection in Africa. The one that's more clinically relevant are types D through K, so D, E, F, and so on. Cause STDs and pelvic inflammatory disease and urethritis and neonatal conjunctivitis. And the other type of chlamydia trachomatis is the L1, L2, L3, causes a lymphogranuloma venereum, which looks a lot like inflammatory bowel disease. You have a primary ulcer, and then you have lymphadenopathy in the inguinal region. How do we treat these? Erythromycin or macrolides or tetracyclines. So macrolides or tetracyclines to treat these. Number three, what's a classic presenting symptom in a patient with Lyme disease? Is it erythema chronicum migrans, which is the expanding bullseye rash, rash with central clearing. Number four, what's the distinction between a Gone complex and a Gone focus? The complex, or the focus rather, is the calcified lung scar, and then when you take that and add the calcifications around the hilum of the lung, then that is the Gone complex. And these are seen with primary tuberculosis, right? The caseous necrosis, the cavitary lesions, that's secondary tuberculosis. Number five, which mycobacteria species fits the following description? Causes leprosy is Mycobacterium leprae. Causes pulmonary TB-like symptoms in COPD patients is Mycobacterium kansasii. Causes a cervical lymphadenitis in children is Mycobacterium scrophasium. Causes a disseminated disease in AIDS patients is MAI, MAC, Mycobacterium avium intracellulare, Mycobacterium avium complex, different names for the same thing. And then hand infection in aquarium handlers is Mycobacterium marinum. What is the rickettsial triad? Is headache, fever, rash. The next one, 25-year-old with mycoplasma, atypical pneumonia. You have cryoagglutinins. What type of immunoglobulins are responsible for the anemia? Is IgM antibodies. And a homeless alcoholic vomits, foul-smelling sputum, has some type of severe pneumonia. This is going to be one of two things. Could be either Klebsiella pneumonia, we said is common in this scenario. Could be an anaerobic pneumonia also. Anaerobes can also be cause pneumonia in this scenario. And the last one, which antibiotics should be used to treat the following infections? For Mycoplasma pneumoniae, just like with chlamydia infections, you're going to use tetracycline or macrolides like erythromycin or azithromycin. For Rocky Mountain spotted fever, tetracyclines. For early Lyme disease, doxycycline. For late Lyme disease, a month of ceftriaxone. For syphilis is penicillin G. And for leprosy, we said dapsone plus rifampin plus clofazimine for 6 to 24 months. And then bacterial vaginosis is metronidazole. All right, let's go ahead and finish up our discussion of antibiotics starting on page 190. We left off with polymyxins. Now let's talk about your antimycobacterial drugs. We just got done talking about mycobacterium. Let's talk about these drugs. So for tuberculosis prophylaxis, single drug isoniazid. All right, that's worth knowing. To treat tuberculosis, you need a 4-drug cocktail, which you see there in the margin. Rifampin, isoniazid, pyrazinamide, and ethambutol. Ripe for treatment, great mnemonic here in first aid. Let's skip a section before we talk about these other ones. So your anti-TB drugs, it mentions streptomycin, and then the four that we just said, the RIPE, pyrazinamide, isoniazid, rifampin, ethambutol. And then cycloserine is another one. Important side effects, ethambutol is optic neuropathy. Make sure you know that. Ethambutol is definitely high yield. I use the E in ethambutol and E for eye side effects. So ethambutol and eye side effects. Red-green color blindness. This is reversible. So once you stop the ethambutol, the eyes will come back to their normal state. But you do have this red-green color blindness with optic neuropathy. You can also have decreased visual acuity as well. So two things go along with that. For the other drugs, hepatotoxicity. So, the TB drugs can be hepatotoxic. So that's something that's worth knowing also. We've been talking about isoniazid as a TB drug. Let's talk about that one on page 191. What's the mechanism? Decreases the synthesis of mycolic acids, which is found in Mycobacterium. Clinical use. It's the only agent used in solo prophylaxis against TB, so we've said that. Toxicity is neurotoxic. It's hepatotoxic. So pyridoxine, which is vitamin B6, can prevent the neurotoxicity. So we've just converted our TB drug cocktail from a 4-drug cocktail to a 5-drug cocktail. The mnemonic was RIPE. Rifampin, isoniazid, pyrazinamide, ethambutol, and now pyridoxine to prevent isoniazid toxicity. Make sure you know that. One other toxicity of isoniazid is it can cause drug-induced lupus. Drug-induced lupus. What antibodies do you see in drug-induced lupus? Antihistone antibodies, right? So something to be aware of also. Let's talk about rifampin next. It's also on page 191. So rifampin has the R's. If you know the R's of rifampin, you're like 90% of the way there with rifampin. So RNA polymerase inhibitor, there's your mechanism of action. These are in the margin on page 191. Revs up microsomal P450. So it increases metabolism of other drugs like, birth control pills and like warfarin. So if you have a patient on warfarin, Coumadin, or birth control pills, they're going to need higher doses while they're on rifampin. Red-orange body fluids is the third R. You need to make sure you warn your patients about this because they start taking rifampin, they're going to freak out when their tears are red, their saliva is red-orange, their urine is red-orange, their vaginal secretions are red-orange. Everything is red-orange with rifampin. It stains your clothes even. And then rapid resistance if used alone. So those are your R's of rifampin. So it mentions it's an RNA polymerase inhibitor. Clinical use. It's used for TB, delays resistance for dapsone. When used for leprosy, what's your leprosy drug cocktail? Dapsone, rifampin, clofazimine, right? 3 drugs. Used for meningococcal prophylaxis and chemoprophylaxis in patients with Haemophilus influenza type B. So those that might be exposed to meningococcal meningitis or Haemophilus influenza type B meningitis, close contacts need rifampin in order to prevent it. It can be hepatotoxic. Again, orange body fluids are rifampin. Let's talk about some of your other antimicrobial drugs. Antimycobacterial drugs on page 190. Mycobacterium avium intracellulare or Mycobacterium avium complex. So what prophylaxis do we give for this is azithromycin. And when do we give azithromycin prophylaxis to AIDS patients in order to prevent them from acquiring Mycobacterium avium complex? Is when their CD4 count drops below 100. It's a number you want to know. CD4 below 100 starts your AIDS patients on azithromycin prophylaxis. How do we treat it? Mycobacteria is very difficult to treat, so here again you need a 4-drug cocktail. You take your azithromycin, you continue it, you add rifampin, ethambutol, streptomycin. What's the side effect of ethambutol? Eye side effects, optic neuritis, right? Mycobacterium leprae, so we've talked about that 3-drug cocktail already. So those are your mycobacterial drugs. Let's go to page 191. Resistant mechanisms for various antibiotics. I don't really have anything to add there, but take a look at that. It is worth knowing. Non-surgical antimicrobial prophylaxis. We've talked about a lot of these already. If you need to prophylax against meningococcal infection, if you're exposed to patients with mycobacterial meningitis, rifampin is going to be your drug of choice. Same thing if you're exposed to Haemophilus influenza type B, meningitis, again, reach for your rifampin. What if you want to prophylax for gonorrhea? When would you want to prophylax for gonorrhea? All right, not when you're going to Vegas, right? You want to prophylax for gonorrhea. Actually, this is for rape prophylaxis. So patients have been raped, and you want to ensure that they do not acquire gonorrhea from this unknown patient. So ceftriaxone is what we use here. Syphilis prophylaxis, we mentioned benzathine penicillin G is how we treat it, so we use the same drug for prophylaxis. History of recurrent UTIs. So you actually have a lot of options here. Patient has recurrent UTIs, you want to prevent them from getting another one. You can use TMP SMX, for long term. You can use nitrofurantoin long term. You can use amoxicillin long term. You can use ceflexin long term. So you can use, you have lots of different options here. I'm not quite sure why your book chose TMP SMX. It's not always the drug of choice for this. Pneumocystis jirovecii, which causes the PCP pneumonia in AIDS patients. So for prophylaxis, we use TMP SMX is one option. When do we start prophylaxing for PCP pneumonia in AIDS patients? When the CD4 drops below 200. CD4 below 200, put them on TMP SMX. CD4 below 100, they're going to be on TMP SMX still and azithromycin, right? What happens if you're sulfa allergic and you can't take TMP SMX? You actually have two other options. It mentions aerosolized pentamidine. Your other option is dapsone. So there's three prophylactic options here. It's dapsone, TMP SMX, or pentamidine. So patients with turbulent heart flow lesions, damaged endothelium of the heart, you do not want them to acquire endocarditis by way of introducing bacteria in the bloodstream because of a dental procedure or a colon procedure or some other clean contaminated procedure. So whenever they go in for these types of surgical procedures or dental procedures, what do they need to take beforehand? They can take penicillin, it's fine. Penicillin V is the oral penicillin, or they can take one of the aminopenicillins like amoxicillin, or they can take ceflexin, which is a first-generation cephalosporin. So any of those are fine to prevent endocarditis in these patients, specifically by your Viridans strep, right, from dental procedures. Treatment of highly resistant bacteria, so MRSA, you can use vancomycin, of course. You can also use linezolide for MRSA. And then for VRE, you can use linezolide or your streptogramins. And we've mentioned the streptogramins earlier. All right, so let's go ahead and take a look at your handouts for this last section, antibiotics. On page 15 of your handout is the last section of antibiotics. Go ahead and look at those questions on page 15, see what you can answer for yourself. We're actually going to go through this page because some of these can be a little bit tricky. So take some time and then we'll go through these together. So go ahead and take a look at page 14 of your Microbiology Part 1 handout, the one titled Mycobacterial Agents. We discussed pretty much everything on this page already, so take a few minutes to look at that. But there are three that I'm going to go ahead and give you the answer to because we haven't really discussed them. We talked about them when we were talking about specific drugs, but let's talk about them as more side effects in totality in all these different drugs. So specifically, we're talking about number 6 here. What drugs are known for causing drug-induced lupus? And you can find this on page 241. The mnemonic that First Aid gives you is HIP. It's not hip to have lupus, HIPP. The H is for hydralazine, isoniazid, procainamide, and phenytoin. So because we were talking about isoniazid, this is a good place to go ahead and memorize this. Definitely high yield. You want to make sure you know these drugs. Now, one other drug category that is not in here is sulfonamides. So go ahead and add that. So you might change the mnemonic to SHIP if that makes it easier for you. So sulfonamides also can cause drug-induced lupus. There's, of course, lots of other drugs that can cause drug-induced lupus, but these are the ones you need to know for your test. And instead of memorizing the 30 drug list, just start with this drug list. Let's skip down to number 9. What drugs are famous for inducing cytochrome P450? So this is on the bottom of page 241. And for your inducers, mnemonic is BCG, like the tuberculosis vaccine, and then PQRS. The B is for barbiturates, C is for carbamazepine, G is for griseofulvin. The P is for phenytoin, Q is for quinidine, R is for rifampin, which revs up cytochrome P450. It induces cytochrome P450. and then S is for St. John's wort. And it mentions at the bottom that quinidine can both induce and inhibit different isoforms of cytochrome P450. Induction is a more important effect. Your inhibitors of cytochrome P450, pick eggs is a mnemonic here for this one. This is the answer to number 10 in your handout. The P is not actually listed here. It's protease inhibitors. Protease inhibitors, your HIV drugs, are actually designed to inhibit cytochrome P450. So that's the P in your mnemonic, pick eggs. And the I is for isoniazid. C is for cimetidine. And the K is for ketoconazole. And then the eggs is for, E is for erythromycin. G is for grapefruit juice. S is for sulfonamides. So sulfonamides as a drug can be a bit dirty, lots of different side effects. They inhibit cytochrome P450, cause drug-induced lupus. And then it mentions that for alcohol use, acute alcohol use can inhibit cytochrome P450, but over time, chronic alcohol use can induce cytochrome P450. So that's mentioned here as well. All right, so go ahead and take a look at page 14 of your handout. Go ahead and answer those questions. We're not going to go over them because we just went through them, but take a few minutes to do that. All right, guys, that's it for antibiotics. And like I said before, antibiotics for step 1 is really not incredibly high yield, unfortunately. I know you guys have been learning a lot about antibiotics for the last few days, but definitely very clinically relevant. So it's not a waste of your time to go through this stuff. But for the next few weeks, as you're studying for step 1 and really honing in on the high yield stuff, make sure you review antibiotics, but don't spend a ton of time on it. Instead, spend a ton of time on autonomic pharmacology. All right, so let's do one last quick quiz here with antibiotics on page 15 of your handout. So take a few minutes to go through that, and then we'll go through the answers. All right, let's go ahead and go through these answers. Number 1, cell wall inhibitor matches the following statement. Next step in the treatment of otitis media, if resistant to amoxicillin, you combine amoxicillin with clavulanic acid. All right, brand name is Augmentin. You guys don't need to know the brand name, but amoxicillin with clavulanic acid. The next one, prophylaxis against bacterial endocarditis and those patients with turbulent heart flow problems. Penicillin V is fine. Alternatively, you can use one of your aminopenicillins like amoxicillin. You can use ampicillin if you want to. You can use a first-generation cephalosporin like ceflexin if you like. Increases in nephrotoxicity of aminoglycosides are your cephalosporins. Sufficient for the treatment of syphilis is penicillin G. That's the IM or IV form of penicillin. Single-dose treatment for gonorrhea is ceftriaxone. What are the clinical uses for the different cephalosporins? First generation, your mnemonic was PEC. For Proteus mirabilis, E. coli, Klebsiella pneumonia, and then don't forget gram-positive cocci. Again, it's easy to remember the PEC. Don't forget the gram-positive cocci as well, which is the main use form. Your second generation cephalosporins, Henpex is a mnemonic. The H is for Haemophilus influenza, and then Enterobacter, and then Neisseria species, and then PEX is Proteus mirabilis, E. coli, Klebsiella, and then this PEX has an S at the end for Serratia marcescens, and again, don't forget the gram-positive cocci. Your third generation cephalosporins are primarily for serious gram-negative infections like Pseudomonas and for gonorrhea, Neisseria gonorrhea. And your fourth generation cephalosporin is cefepime. It's a big gun, works well against gram-positives and against gram-negatives like Pseudomonas. Number 3, what are the clinical uses for the macrolides? The mnemonic I gave you guys was pus. The P was for pneumonias. Your atypical pneumonias is what we're talking about. Legionella pneumophilia, Mycoplasma pneumoniae, and Chlamydia pneumoniae. So that's the P in pus. U is for URIs, so it covers gram-positives like strep throat, strep pyogenes is covered by macrolides. And then the S is for STDs like chlamydia and gonorrhea. The next question, what are the side effects of aminoglycosides? The mnemonic here was NOT for nephrotoxicity, ototoxicity, and the T was for teratogenic. Number 5, what drugs have photosensitivity reactions? Remember, your mnemonic here is SAT for photo, S is for sulfonamides, A is for amiodarone, which is an antiarrhythmic, and then T is for tetracyclines. Number 6, classifying the following drugs, you need to be able to know which drugs fall into which categories. Minocycline is a tetracycline. Gentamicin is your prototypical aminoglycoside. Erythromycin is a macrolide. Tobramycin is an aminoglycoside. Azithromycin, Zithromax, is a macrolide. Doxycycline is tetracycline. Don't confuse doxycycline, which is a tetracycline drug, with doxycycline, which is a penicillin drug. Easy to mix those up. Amikacin is an aminoglycoside. Neomycin is an aminoglycoside. Clarithromycin is a macrolide, and clindamycin is none of the above. It's its own drug category. The next question, what is a disulfiram-like reaction? What drugs cause disulfiram-like reactions? Disulfiram-like reaction is discussed on page 94, first aid. And what's going on here is disulfiram inhibits acetaldehyde dehydrogenase. So when you inhibit acetaldehyde dehydrogenase, you don't end up forming acetate from alcohol. You form the intermediary step, which is aldehyde, or acetaldehyde. So as acetaldehyde accumulates, that makes you feel very uncomfortable. You start having nausea, flushed skin. You might actually start throwing up. Blood pressure might drop a little bit. You get very uncomfortable. It's kind of like having a hangover. What drugs cause that reaction? We saw this on page 241. They include metronidazole, certain cephalosporins, procarbazine, which is an alkylating agent used in the treatment of cancer. Your first generation sulfonylureas, which we don't really use so much anymore. They're old-timey diabetic medications. And then, of course, disulfiram causes a disulfiram-like reaction. Number 8, the different agents for prophylaxis. For gonorrhea prophylaxis in rape patients, you would use ceftriaxone. For syphilis prophylaxis in the same group, you would use penicillin G. For recurrent UTIs, we mentioned lots of different drugs. You can use TMP-SMX. You can use nitrofurantoin for prophylaxis. You can use amoxicillin. You can use ceflexin. So lots of different drugs can be used here. In general, you're trying to cover E. coli primarily. For pneumocystis jirovecii pneumonia, you can use TMP-SMX, which is definitely the standard. Alternatively, you can use dapsone, or you can use pentamidine. Exposure to meningococcal or H-flu type B meningitis, rifampin. And endocarditis prevention in a patient with turbulent heart flow disease. We talked about this one in number 1. You can use penicillin V, you can use aminopenicillins, you can use first-generation cephalosporins. And the last one, what drugs are known for inhibiting cytochrome P450? Your inhibitors are your PIC eggs was a mnemonic I gave you guys, and the P was for protease inhibitors. I was for isoniazid, C for cimetidine, K for ketoconazole, E for erythromycin, G for grapefruit juice, and S for sulfonamides. All right, so that's pretty much it for antibiotics, and that's it for today. So go ahead and study on your own for a little while, and we'll see you for the next lecture.